Okay, this last section of this PowerPoint for elbow anatomy is going to deal with the muscles. So again, we'll talk about primary muscles of the elbow that do flexion and extension, and then we'll talk about the muscles in the forearm that either act on the elbow, so they actually help with flexion and extension, or they do supination and pronation at the forearm, or we're going to talk about them because they're in the area, but they may or may not at this point affect the elbow. We'll talk about some of the wrist flexors and wrist extensors. Although they're affecting the wrist, they're located at the elbow, so we're going to talk about them now a little bit, and then we'll go into more detail with them when we do the hand and wrist chapter. So starting off looking at the muscles that affect elbow flexion and extension. We have 3 primary muscles that are responsible for elbow flexion, and we have 2 muscles that are responsible for elbow extension. And we'll talk about each of these individually. So the muscles of the anterior arm obviously are going to do elbow flexion. We have our bicep brachii, and then we have underneath that we have the brachialis. And there's pictures of these individually. Again, for all these muscles, you have to know origin, insertion, action, and innervation. So start working on that now. We've already talked about the bicep brachii and what it does at the shoulder, but now we're going to focus on what it does at the elbow. So there are 2 heads of the bicep brachii. It does do shoulder flexion. It does do shoulder adduction. But now we're talking about the elbow and the forearm. So at the elbow, it is going to be a flexor, but most importantly, the bicep brachii is your primary supinator. So when you are in pronation, the bicep brachii is the strongest and most powerful supinator of the forearm. But it will help with elbow flexion as well, obviously. It really depends on what position your hand is in. Muscles are going to work the best when they're in the most advantageous position. So if I decided to do bicep curls with my palm facing down, that is not a good position for the bicep brachii. Based on the origin, based on the insertion, if you do elbow curls, we'll say elbow flexion with your palm facing down in pronation, you are not getting very much help at all from your bicep brachii. Yeah, it's still going to help, but it's not going to be your primary muscle working. If you do that same action in a supinated position, now you put the bicep brachii in a good, advantageous position, so now you're going to get a lot more help from the bicep brachii. So if you've done different weight training techniques, and you've done different kind of elbow flexion curls, and you've done them with your in supination, in neutral, and in pronation, pronation is a lot harder. You're not as strong because you're not getting help from the bicep brachii. Your brachialis is going to be this one here, and it's going to sit directly beneath the bicep brachii. So it sits deep to the bicep brachii, and this is going to be your primary elbow flexor when your forearm is pronated. So the bicep brachii helps with supination, so when you do those palm down curls, those pronation curls, when you do elbow flexion in a pronated position, then you're not getting much help from the bicep brachii, but you are stressing primarily the brachialis. So hand positioning is going to change which muscle you're going to use, but the brachialis is active through the entire flexion. So specifically here, your origin, we have our 2 heads. Our long head is going to be supraglenoid tuberosity and your glenoid labrum. The short head is still the coracoid process. The insertion point is going to come down here, and it's going to be on that radial or bicipital tuberosity of the radius. And then we'll have this stuff called aponeurosis. It's just an expansion that's going to help with the strength of the structure, but it's a long, flat tendon type structure. So what it's going to do at the elbow, the bicep brachii will do elbow flexion, and it will do forearm supination. So those are the 2 big things at the elbow. It does shoulder flexion, it does shoulder adduction. We have already talked about all that. And it is still innervated by the musculocutaneous nerve. The brachialis is a new one here. So this is a picture of the bicep brachii taken off. Here is our brachialis. Like I said, it sits deep to it. It does not cross the shoulder. It is only on the distal humerus. So the origin is going to be the distal 1/2 of the anterior humerus. So here's our humerus, distal 1/2. And then it's going to insert into the coronoid process of the ulna and your ulnar tuberosity, which is just a bump on the top of the ulna, which your coronoid process is right there. So it's going to actually insert not on the radius but the ulna. So the bicep brachii is going to be over here on the radius. The brachialis is going to insert on the ulna, which is why it's not near as affected with supination and pronation because the ulna does not move positions if we're in supination and pronation. Its primary action is going to be just elbow flexion, especially in a pronated position. Like the bicep brachii and the coracobrachialis, the regular brachialis is also innervated by the musculocutaneous nerve. So all three of the muscles on the anterior humerus, the bicep brachii, the brachialis, and the coracobrachialis, are all going to be innervated by the musculocutaneous nerve. The other muscle that's going to help us with elbow flexion is going to be our brachioradialis. This muscle is going to start up on the supracondylar ridge. So if you look at a humerus, let's see if I can draw it here for you. If you look at the humerus, you see that it starts to go out as it comes over, and then it's going to come back in and it gets skinnier up here. These, as it starts to flare out, that's going to be your supracondylar ridges. It's a very good picture. So it's going to originate on the lateral supracondylar ridge. So here are condyles. It's going to start above the condyles, basically. And then it's going to cross, stay on that lateral side, and if we're in anatomical position, it stays lateral the entire time, and it's going to insert on the radial styloid process. It is not going to cross the wrist joint. It will not have any action at the wrist joint at all because it does not cross that joint. So your radial styloid process is this point here at the very end of the radius. So it is a long, skinny muscle. This is the only flexor in the posterior compartment. So unlike we have the we have the bicep brachii and the brachialis are on the anterior side. This is really considered the posterior compartment, and it is more lateral to posterior, so it's not really by the other flexors. The brachioradialis is going to help with elbow flexion, especially elbow flexion in the thumbs up position. This is how you actually can have it stick out and palpate. You can see it very clearly when you do resisted elbow flexion in a thumbs up position. It's the muscle that sticks out, but it does start on the lateral humerus and goes down to the radial styloid process. Based on which position your hand is in, it's also going to help with forearm pronation. So this is where it's important to understand how it crosses the joint, and if you understand that, you can see that it will help if you are in supination. It's going to be lengthened, so it will help you move over to pronation. Because it is in the posterior compartment, it's going to be innervated by the radial nerve, like the triceps. The triceps are innervated by the radial nerve. So it's in the posterior compartment. They're going to share an innervation, in this case the brachioradialis. Even though it's a flexor, it's located in the posterior compartment, so it's innervated by the radial nerve. Your tricep brachii, we've already talked about in the shoulder. There are three heads. We've talked about the long head. It's going to originate on the infraglenoid tuberosity, but there are two other heads, the lateral head and the medial head, and these are going to basically just cover the entire posterior part of the humerus. So the lateral head is actually defined as the proximal half of the humeral shaft, and the medial head is the posterior medial surface of the humerus. So again, this is one of those examples that I'm not overly stressed about you knowing the exact location because it's so broad, because there's going to be, it's not one origin, but basically the tricep is touching and has origin and actually has fibers connected to the bone all the way down the posterior part of the humerus. So it's a very broad, long origin versus a one specific location. So the long head, yes, you have to know that that's on the infraglenoid tuberosity, but the lateral head and the medial head, they're basically attached to the entire posterior part of the humerus. They are going to all collectively insert with one tendon into the olecranon process. Triceps still pretty easy. At the elbow, it just does elbow extension, but the long head will do shoulder extension as well. It's in the posterior compartment, and it is innervated by the radial nerve. The anconeus is one that you may or may not have heard of before. It's a small muscle located on the posterior part of the elbow. It really is this just small triangular, basically slip of muscle. It is an elbow extensor, but really it does more to help stabilize the muscle. Big muscles tend to be used for primary action. Small muscles tend to be used as proprioceptors and stabilizers. It's a good example of the rotator cuff. The rotator cuff are small muscles. Your pec major, your lat, your teres major, those are big muscles. Big muscles do big actions. Small muscles do a lot of stabilization. So the anconeus is a small muscle. It's going to start on the lateral epicondyle, and it's just going to kind of rotate around the back and insert on the posterior part of the olecranon and the ulna. So it's just going to go to the back there. Here's a posterior view. You can kind of see it touching the back of the ulna. Its primary action, like I said, is elbow extension, but it will also stabilize the ulna during supination and pronation. So it's going to act as a proprioceptor and a stabilizer during those movements. It is on the it's going to be on the lateral part of the elbow, though. And because it is on the back side and it is an extensor, it's going to also be innervated by the radial nerve. So those were the muscles that were working on elbow flexion and extension. These next muscles are going to be talking about the effect of forearm supination and pronation. So these two pictures really help you identify which muscles are responsible for supination and which ones are responsible for pronation. And this is where I'll say it again, if you understand where the muscle starts and where it ends, then you can understand what it actually does. Especially with supination and pronation, because muscles are going to end up wrapping around the radius to pull it in and to pull it out. So it's really important to understand how these muscles are situated so that we understand the movements. So we're going to be talking about the supinator and the biceps brachii, which we've already have for supination. The bicep brachii is our primary supinator. It's the biggest and the strongest. But we also have the muscle called supinator. So when we're in, and we'll talk about this more specifically, but when you're in supination already, it's in a shortened position, so it's just running from the lateral epicondyle down to the radius. But when we go into pronation, it actually stretches out and lengthens, and it's going to put tension on it so that when we do go into supination, it's able to pull a lot easier. And we'll practice this more in lab too, so you'll be able to experience it with the models and actually look at it, and hopefully it'll make more sense. Our two pronator muscles, one is called the pronator teres, and the other is called pronator quadratus. So it's kind of giving away the action. The pronator teres does pronation, and so does the pronator quadratus. These are two relatively small muscles. We are much stronger in supination than we are in pronation. Pronation is a much weaker action because the muscles that do it are a lot smaller. The pronator teres is going to run straight across from the medial epicondyle over to the lateral part of the radius. And your pronator teres is going to be very deep, square, rectangular type muscle that's sitting just above the interosseous membrane. They are lengthened when we're in supination, and this is the radius right here. So it's lengthened all the way down. So when we want to go into pronation and turn our wrist over, the pronator teres is actually taking it and pulling the radius over into pronation. This again is helping you pull this way. So now this muscle is shortened and our bones are in pronation. I know it's kind of hard to understand, so make sure that you spend some time in lab when we cover this, looking at the bones and seeing how they work together. Individually here, the supinator obviously does supination, but again, looking at the different pictures, it's going to start in the lateral epicondyle, part of the RCL, part of the annular ligament, so it's all going to be in that area. So if one's damaged, multiple could be damaged as well. Multiple structures could be damaged. It'll also have some part on the ulna as well. So it's got two origins. Then you can see that it wraps around the radius and actually inserts on the proximal part of the radius. In this position, where this is probably a thumbs up, the hand is probably thumbs up, so that this, you can see that the supinator is wrapped around. It's not inserting out here, it's inserting on kind of the medial part of the radius, so that when it actually wants to go into supination and actually pull it over, it's going to pull and rotate it this way into a palms up position. So it's going to uncoil and rotate it out. Here's another picture where we are in, this one is going to be in pronation, because you can tell it's all the way wrapped around. Because the supinator is wrapped around the radius, we're in pronation, and it's getting ready to pull it out into supination. So the supinator is going to be our prime mover of unopposed forearm supination. So, you know, when I'm just sitting here talking and I'm doing supination and pronation with no weight in my hand, the supinator is doing the work. But when I have any kind of resistance to forearm supination, that's when the bicep brachii is going to kick in and actually do the supination for me. So the supinator is for unopposed or no resistance. The bicep brachii is for when we actually have resistance. And it is innervated by the deep radial nerve. And the deep part is important. It's going to be a branch off of the regular radial nerve. The pronator teres is going to run from the medial epicondyle and part of the coronoid process down to the lateral radius. It's going to run straight across, so shooting from the medial part over here to the lateral part. There is some part on the radius, but it's primary. On the ulna, but its job is to basically pull into pronation. In this picture right here, because the bones are parallel, we can tell that this skeleton, this picture, is going to be in supination. So if the pronator teres pulls, it's going to pull and rotate the radius, and we're going to end up in pronation. So that's how it's going to end up doing its pronation. Because it does cross the elbow joint on the anterior side, it will help with elbow flexion, but obviously based on the size and the position of this muscle, it's not a primary elbow flexor, but it is going to help because it is in that location. But its primary job is pronation. Based on where it's at, you're just going to have to memorize this one is the median nerve. Now we're not going to go through the other, we'll talk about them as a group right now, but this is a picture from Hoppenfeld. This is how I always remember the muscles that are going to all share an origin. So the pronator teres, and then there are three muscles, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. We'll talk about those a lot more detail in the hand and wrist chapter, but together all four of these muscles, all four of these right here, are all going to share a common origin on the medial epicondyle. So they're going to end up having one common origin. So we're going to talk about them all together. Well, the pronator teres affects the elbow, so we're going to talk about that specifically right now. But each of these fingers and thumb are going to represent a muscle. And this is to this day how I remember which one is which. The pronator teres runs straight across your arm toward the radius so it can pull it over. That's your thumb. And you'll have your flexor carpi radialis, runs over here toward the thumb. Palmaris longus is straight down the middle. And flexor carpi ulnaris goes to the ulnar side. This is still, they all share, the heel of your hand goes on the medial epicondyle because that is the common origin that they share. And again, we'll go through that a lot more in the hand and wrist section. You'll have to know what all those muscles mean. But right now, the palmaris longus, you can remember that it is the thumb in that picture. Not palmaris longus, the pronator teres. The next one is your pronator quadratus. This is your other pronator muscle. It is not very strong, and it's not even very biomechanically advantageous. So even if it was a strong muscle, based on how it sits, it has a very short lever arm, so it's not going to be able to pull very hard. So it is going to help with pronation, but it's not going to do all that much work by itself, which is another reason why pronation is a fairly weak action. It's going to start on the anterior distal part of the ulna, and it's going to run over to the lateral part of the radius. So in, again, this position, the bones are parallel, so we're in supination. So when it does pull, it will pull it over into pronation. It's just very small. It's a very deep muscle. This is going to be located deep to all of your flexor tendons. Basically, the interosseous membrane is going to separate anterior from posterior. So what you have here is an interosseous membrane, and then immediately superior to that, or immediately above that, is going to be your pronator quadratus. So it's going to sit very deep in the forearm. And it's going to have the nerve as your anterior interosseous nerve because it sits so close to the interosseous membrane. It sits on the interosseous membrane. It is your anterior interosseous nerve. And I mentioned the wrist flexors already. It's the hand. So the wrist flexors in this picture are all going to originate on the medial epicondyle. And they're going to, so palmaris longus here, your flexor carpi radialis, your palmaris longus, did I say it again? Your pronator teres right here, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. That's your hand. So your thumb, index finger, middle finger, ring finger. Your pinky doesn't get to be anything. Again, we'll cover all those later, but what you have to know right now is that the common wrist flexor group, which is these four muscles together, are all going to share an origin on the medial epicondyle. The common wrist extensor group are going to share an origin on the lateral epicondyle. So because we're covering the elbow, we have to know what other structures are in the area. So we do need to know at this point, wrist flexors are on the medial epicondyle, wrist extensors are lateral epicondyle. If you forget that, do resisted, even to yourself, do resisted wrist flexion, which muscle groups pop out? Do extension, which muscle groups pop out? Follow them to their origin, and then you should be able to tell me if they're flexion and extension. Although we're going to talk about them in this chapter, they have no effect on elbow motion. So it does not affect elbow supination and pronation. It does not affect elbow flexion and extension. But we have to know what they are and where they're at. The next one are the nerves. We have major nerves that are actually very large, running through and around the elbow. We have the median nerve, the ulnar nerve, and the radial nerve. You should know these at least by name because you drew them as part of your brachial plexus. But these are actually very substantial nerves and can be injured relatively easily in the upper extremity. Coming off the brachial plexus, the median nerve is going to shoot straight down through the anterior part of the elbow joint. The median nerve is going to be within the cubital fossa. So the cubital fossa, like I said before, cubital is always going to mean elbow. The cubital fossa, if you actually look at your elbow joint, that indentation, the hole that you're going to have, because fossa means indentation or hole, that middle part on the anterior surface of your joint is considered your cubital fossa. You have a popliteal fossa in your knee. It's the back part of your knee. Well, we have the cubital fossa in our arm, and it's the anterior part of our elbow. So the median nerve is going to be deep in there, and it's actually going to be very close to, or basically run right past where the bicep tendon inserts. The ulnar nerve is even more commonly injured based on how it runs. It's going to start up, come off the brachial plexus, and it's going to go down around the medial epicondyle. This is your funny bone. Your ulnar nerve is your funny bone. It's going to sit in that cubital fossa, which I'll talk about here in a minute, and then it's going to continue on down to your pinky side. Your radial nerve is actually a little bit less, it starts to get a lot smaller as it goes down. It's going to travel along the posterior part of the humerus. It is going to go, it actually travels underneath the brachioradialis. So the brachioradialis actually protects it during daily life. Then it's going to start to break off, but it is going to go, it's going to feed the posterior structures of the forearm. So we're going to go into, I forgot there was in depth here. So like I said, your median nerve does run anterior. Here is the pronator teres. They don't have the bicep tendon on here, but the bicep tendon would come across this way, right here. So we have this fairly large, I mean, when you look at the scale of this size of this nerve, it's not off. It's not blown up for this picture. The nerve is actually this large. It runs with the brachial artery, so the nerve and artery run together through the anterior. So here is your cubital fossa, just this triangle area in here. So we consider the cubital fossa. So within that, you have your bicep tendon, you have your you have your median nerve and your brachial artery are all together. And then the median nerve is going to continue down to the hand and wrist and actually run through the carpal tunnel in the wrist, which we'll get to in the wrist section. The ulnar nerve, like I said, is one of the major ones that we have a problem with in athletics. It's going to run on the medial side of the humerus, so up here, medial side around the medial epicondyle. So it actually sits in a groove in the medial epicondyle. It's actually called the sulcus for the ulnar nerve. So if you look in lab, make sure you grab a bone, look at the humerus, and you'll see that there's a groove in there. And that's where the ulnar nerve is going to sit. After it gets through the elbow, it's going to go all the way down to the pinky side of your hand. The interesting thing here is this is a close-up of the lateral side, and here is the this is actually posterior side. Here's your olecranon right here. Here's your lateral epicondyle, and then here's your medial. You can see the ulnar nerve actually sits in that groove, like I was talking about, and it's actually covered up by the flexor tendons. So that common flexor group with the pronator teres, this is that tendon right there. So it actually forms a tunnel. The bone is underneath, the medial epicondyle is underneath, then you have the ulnar nerve, and then you have the flexor tendons of the wrist and the pronator teres are all going to actually have that common tendon. It's going to cover it up. That's called the cubital tunnel. The cubital tunnel is that tunnel formed by the wrist flexors that actually keep the ulnar nerve in place. It's very superficial. If you relax your hand, you can easily palpate and actually move around, and you can feel how large it is. It is not small. When we think of nerves, we tend to think of really small structures, but you can feel it, and it's pretty substantial. It's easily palpable. But when you have direct trauma to it, because it's so superficial, that can cause a lot of pain and discomfort. If it's stretched for too long, like if you fall asleep on your arm and then all of a sudden your pinky and ring finger are tingling, that's because you stretched your ulnar nerve. Or if you get hit in the area, you might not have actually damaged the ulnar nerve, but if there is swelling, the swelling can cause compression of the ulnar nerve, giving you neurological symptoms. So this is something that we do see relatively common, is problems with the ulnar nerve. The radial nerve, like I said, it's going to run posterior, so it runs out of the brachial plexus posterior. It actually follows directly underneath the brachioradialis. The brachioradialis is going to start on the lateral supracondylar ridge, so that's right here, and it's going to insert on the radiostellate process. Well, that's the exact pathway of the radial nerve. There is an offshoot. This is going to be your deep radial nerve. So when you did see that one muscle that was innervated by the deep radial nerve, that's going to be an offshoot of the regular radial nerve. The radial nerve is going to end up feeding a lot of the posterior forearm muscles. And then we have our artery. This is a major thing because we have, just like we said, a posterior SC dislocation. If it has pressure on the subclavian artery, then we're cutting off blood flow. Well, if you follow this, the subclavian artery comes right off the aorta, and then it becomes the axillary artery, and then it's going to become the brachial artery. So after we get out of the armpit, it becomes the brachial artery, and it's going to be responsible for feeding the entire upper extremity. It is just one long tube all the way down the humerus. Obviously, it has offshoots that feed these structures, but one long primary tube that's bringing the blood, and then right past the elbow in this picture, you can see that right past the elbow, it breaks off into your median and, to your radial and ulnar arteries. But all the way from basically from the armpit down past the elbow, it's all just the brachial artery. So it's a continuation of the axillary, like I said, divides into radial and ulnar, and it's going to actually run through the cubital fossa with the median nerve. And then our cubital fossa. So like I said, our cubital fossa is the indentation on the anterior side of the arm. You do have to know what actually creates this fossa. So the superior part of the fossa is an imaginary line. It's not real. It just creates the top part of our triangle. So that is our superior part. The medial part, when we look at this, the medial is going to be the forearm flexors. So this group together right here, this one specifically is the pronator teres. So technically, the pronator teres forms the medial part of the triangle, or the cubital fossa. But the forearm flexors together create that. And then your lateral side is the extensors, and your brachioradialis are going to help form the extensors of the cubital fossa. The floor, the bottom of this, is going to be your brachialis. So if we take this aponeurosis out of the way, then we can actually see the brachialis right over here, coming straight down toward the ulna. And then the supinator is actually going to be down there as well. The supinator is going to be wrapped around this way. It's also considered the floor of this cubital fossa. Then contained inside the fossa, we have the brachial artery, which we just talked about. So that's the brachial artery coming straight down here. We have our median nerve that runs with the brachial artery. The radial artery is going to be more posterior, but it's considered in the fossa as well. And then our bicep brachii tendon, which you can't really see through the aponeurosis, but actually shoots right in there. So if you look at bicep brachii, whatever I said, bicep brachii, brachial artery, and then your median nerve are all going to be in there together with some of the radial nerve as well. And then a close-up of the cubital tunnel, which I've already talked about. But the cubital tunnel, on the lateral, on the medial side here, the medial epicondyle, there is that sulcus for the ulnar nerve. The ulnar nerve sits in that sulcus, and it is covered up by the flexor tendon group, the origin, and together that is called the tunnel. So it's the cubital tunnel, It's a tunnel for the ulnar nerve to pass through.